This time on The Procedure. The aortic valve is the final doorway in the heart that allows blood to be pushed out of the heart to the aorta, and in turn out to the rest of the body. When this valve becomes narrowed, usually due to aging and calcification, it is called aortic stenosis. These damaged heart valves no longer allow the heart to pump blood out efficiently, causing patients to feel chest pain, dizziness, shortness of breath, and fatigue. Historically, severe aortic stenosis has been treated through open heart surgery, where the old valve is cut out and a new aortic valve is sewn in. While this surgery is very successful, some patients are too sick, too old, or too fragile to undergo such an invasive surgery. Recently, a new treatment has emerged, where doctors can replace the aortic valve from within, using catheter-based non-surgical techniques by directing a new valve up through the aorta and deploying it right over the old damaged valve. Today, we will take you into the endovascular lab to see one of these procedures firsthand, a procedure that is revolutionizing heart valve treatment and returning patients to the life they once lived. The procedure is made possible by educational grants from Medtronic and Siemens Healthineers.
And welcome to The Procedure. I am Brad Perry, your host, and I'm standing here with Dr. Rizik, who is pretty much educating me and you out there on this amazing surgery that we're going to be seeing today. Good morning, doctor. How are you?
Good morning. It's so good to have you, and we're delighted to have Dr. Robert Riley, our Director of Cardiovascular Surgery. So we have an interventional cardiologist and a cardiovascular surgeon working together on these procedures today.
This is a live heart procedure. It is a aortic valve replacement. And let's talk a little about that, because last time we were here, we did a stent, and then before that, we did a repair.
We did a valve repair.
So what is the difference that's going on here?
This is a valve replacement. As you remember, the repair we did, we used non-surgical, catheter-based technique. And we were able to repair the valve. This time, we're going to actually place a new valve in the body, in the old aortic valve, and in doing so, we're just going to kind of wallpaper over that old valve, and we'll give this patient a brand new functioning valve compared to the degenerated valve that he has right now.
Wow, and I know we're preparing for this. It's going to be amazing. We have some stories to talk about and to explain to you, but then we will be going through this surgery, which again is just amazing. And first time, well, not first time, but before, you really wouldn't have the two doctors in here like this, would you?
Right. You know, a lot of the catheter-based procedures are like TAVR, what we're going to show today, transcatheter aortic valve replacement. A lot of those procedures just have an interventional cardiologist. We have a surgeon, and this is a new heart team approach where the interventional cardiologist and the surgeon work together on a non-surgical procedure. Now, Bob, this is a catheter-based non-surgical valve replacement. Are we still doing open heart surgery on valves?
We still are. We're still doing open heart surgery, but it's not necessarily the traditional open heart surgery that you might have thought of, where we go through the center of the chest. We still do that for some operations, but for the aortic valve surgery, we're doing more and more minimally invasive or keyhole or...
Yeah, I wanted to make that point. You've been a pioneer and an innovator in minimally invasive surgical valve replacement, and so we really have choices for our patient, don't we?
I think we have a broad spectrum of choices, from a traditional full incision to a small incision to a catheter-based. So the whole gamut is available to the patients here.
And that's the beauty of the heart team working together. We work together and we make a decision together as a team what would best fit this patient.
Yeah, so we want you to sit back, pay attention, because this is life-saving, and you might have someone in your family that might need to have this surgery. So once you learn what's happening, you can talk with them, help them, educate them, and that's what these surgeries are about.
You know, the leading up to this procedure, I thought the most fun part of this was talking about the pioneers in catheter-based procedures. We had a chance to talk to them last week, two really, really committed pioneers in the early days.
Yeah, it was amazing. So please meet the pioneers.
So here we are in Scottsdale, Arizona, and only a few miles from here, there was a meeting at the Phoenician. Dr. Dietrich, a mentor for many of us here in Arizona, was conducting an international meeting, and a doctor from Europe, a Dr. Henning Rudd Anderson, came to that meeting. And it was only a few miles from here. As he was sitting in the audience at this meeting, the light bulb went off, and he came up with the idea of replacing heart valves non-surgically by going up through the leg. He actually came up with this concept of TAVR. Dr. Anderson, how are you? It's very nice to be with you today.
Thank you.
You know, we have an audience of non-medical people who want to hear your story about how you came up with the idea for replacing valves non-surgically with this technology called TAVR.
I was attending a meeting there back in '89, one of the meetings arranged by Professor Dietrich from the Arizona Heart Institute. And I was listening to some of the pioneers from that time in '89. And then while I was listening to one of the great guys, his name is Julio Palmas, he invented the balloon expandable stents which you can put into the coronary arteries. So when I was listening to him at that meeting, I suddenly got the idea that, oh, Henning, why don't you make this stent much, much bigger and then put a valve inside? Then it should be possible for me to implant artificial heart valves. So I simply went back home, built something like that, and did the first in animal 2.5 months later.
When you were at the meeting in Scottsdale, did you take notes, or I understood that you originally wrote your original ideas on a napkin?
Maybe on a napkin, I really can't remember anymore. I know I have so many documents in my library from the old days, and maybe something is hiding out there, I don't know.
There's a story also that you carry dear to your heart, because this is amazing, and I think, Dr. Rizik, you were telling me it's napkin to... From
the napkin to my father, you came up with a technology that ended up being life-saving for your father.
At that time, my dad was 86, and he had a severe aortic stenosis, a calcified heart valve. And I found out about it, and I said to him, "Oh, Daddy, you have to get some kind of treatment." And of course, there were two kinds of treatments for this disease. It was either standard open chest surgery, where the surgeons put in a new valve. Alternatively, it was my invention it should be treated with. I think it's the best gift I have ever given my dad. He lived for 8 years. He died 1.5 years ago in the age of 95. Not from cardiac symptoms, but he was an old man.
When you first thought of this concept, did you ever imagine that this would explode the way that it has and really supplant surgical treatment for aortic valve disease?
When I came up with the idea 32 years ago, nobody believed in it. People said that, I remember my own professor, he said, "Henning, it's impossible, you cannot do that. But go on, try, but you cannot do that, it's impossible." And, there were so many people at that time which didn't believe in it. Some of them actually got angry because there was a medical doctor coming and say, you can put heart valves in without doing surgery. But it is the normal way. If somebody comes up with let's say, a disruptive invention, which is going to change the world, it takes a lot of years.
Isn't that amazing?
And it's the same. It's the same. This is medical science. But also, if you are an author, come up with a new way of writing books, or if you're a painter and I start to paint in other ways, it's quite the same process. There's a lot of resistance from the community, and it takes you a lot of years to come through.
Dr. Anderson, we can't thank you enough for being a part of this. It's just such an honor to hear your experience and the stories and the origins of TAVR, and for the many patients whose lives you've affected. We're so grateful. Thank you very much for joining us.
Thank you, and give my regards to your audience down there.
Brad, now what I would like to do is introduce you to my mentor and actually the innovator who performed the first transcatheter aortic valve replacement, or TAVR, in the United States, Dr. William O'Neill. Dr. O'Neill, if you don't mind, give us a little bit of your perspective on how this all started. What were the growing pains in this space?
Well, we did the first TAVR in North America in February 2005. A gentleman that was a car dealer that was, I met him on Christmas. He was in his CCU bed crying uncontrollably because he was told that he had no hope, that he had a bad heart, and that he had a bad valve. And on Christmas Eve, I did a complex angioplasty to fix his coronary arteries. He got better from that. We also did a valvuloplasty, stretched the valve to try to give him some relief. And he did fantastic for about a month, but then the valve started to re-narrow. And we'd had this protocol available that had just gotten approved mid-January. So early in February 2005, we brought him to Beaumont. We brought him to the cath lab. And we were able to go through his vessels into his heart and then deploy the valve. And the valve procedure went great. The patient did fantastically. He lived for 6.5 years, and I still have a picture of him sitting in his hot Mustang convertible. He told me that he got it up to 100 miles an hour to celebrate his 1 year after his TAVR. So for me, this was the first successful TAVR, the first successful one that was done in North America, and it really led me to be a real believer that this could be absolutely life-saving breakthrough technology for very ill patients.
What is the future in terms of what we're going to see in terms of the numbers of these types of TAVR procedures?
We're on the dawn of a new day where very little valvular intervention is going to be done surgically. I think the vast majority of interventions, aortic, mitral, tricuspid, are going to be done with transcatheter techniques. Open heart surgery for a replacement is almost, in our institution, is really rare now. So we're doing this, but the procedure just gotten infinitely better, safer, more usable. It's a very similar analogy to angioplasty and to then stents and then to drug-eluting stents. I mean, the thing that's wonderful is that the combination between physicians and industry is indispensable for medical progress. Without us in the cath lab knowing what the problems were and working with industry to fix the problems, none of that would have ever happened. And the brilliance of industry is that they can come up with better, smaller, safer, more deliverable products. So it's just a dream now. I mean, we did 6 TAVRs today and we were done by 3 o'clock.
Wow.
So,
You'd never be able to do 6 open hearts on a Thursday and be done by 3 o'clock.
Yeah.
Always great to talk to you, Dr. O'Neill. Thank you so much for sharing your experience with us.
Take care.
Thank you, doctor.
My name is Sally. I am a full-time artist. This is my working studio, as well as the home gallery that people come to sometimes. My husband died 7 years ago, and so that gave me a lot of time to consider what I was going to be doing with my life, and looking at the current reality to see what I would like to be doing, and of course it was art, because that's always been what I have enjoyed. Both of these paintings are done with alcohol ink. This one is done on a tile in February of 1972. I became Fountain Hill's very first resident. I was very healthy. My husband and I were country western dancers and danced with a group and danced in parades. And I was shocked to be diagnosed in 1999 with non-Hodgkin's lymphoma. That started a saga that lasted until 2006. I know that all the papers that I signed for chemo, all warn you that there could be deterioration in the heart functioning. And I dismissed it pretty much because I just really wanted to survive and figured if that's the case that, we could deal with it. I didn't realize, because I had lymphoma and a lot of years when I wasn't as strong, I was accustomed to resting when I needed to. I thought maybe it was aging. So I was very surprised to discover there was actually a deterioration that needed correction. And it took me to Dr. Rizik. 2 years ago, I needed to have the aorta valve replaced and was able to have that done with the TAVR procedure.
What's unique about Sally is not just her case from a medical standpoint, but it's who she is as a person. She is a fixture in the art scene in Scottsdale. She had aortic stenosis, but it was a unique case. She had also received radiation therapy to the chest, which can set up an inflammatory process in the chest and with the aortic valve, and we believe that was a significant contribution to her development of aortic stenosis. Because of the radiation therapy to the chest, it becomes sort of a hostile environment for performing open heart surgery. It makes open heart surgery even higher risk, and therefore transcatheter valve therapy made sense to us.
Aortic stenosis is when the aortic valve starts to narrow. Now, the aortic valve is the valve which allows blood to flow out of the heart from the main pumping chamber of the heart, the left ventricle. That valve can wear down over time and become calcified and thicken. That prevents it from opening normally and puts a lot of strain on the system and minimizes the amount of blood flow that can leave and get to the rest of the body.
After evaluating Sally, we determined that she was an excellent candidate for a transcatheter aortic valve replacement, where we were able to insert a valve through the leg and pass it up through the arteries to her heart and deploy or release this valve inside of the old valve that wasn't working. This valve holds the old valve open, out of the way, so the new valve inside of this works normally.
We were able to adequately implant the TAVR valve, and there was almost immediate improvement in her symptoms.
I didn't realize until the procedure was done and I felt healed that I was so much more energetic, and that I started taking on all kinds of commitments because I'm happiest when I'm busy.
It's funny, Sally's world and our world, she talks a lot about creativity, and so much of what we do is based on science. But like Sally, so much of medicine and TAVR and all of the highly technical things we offer are really also artistic. There's a lot of art to what we do, not just science.
I think that art is partly an attitude. I've had so many hard life change experiences in losing my sister to cancer, and then 2 years later my daughter to cancer, and then 2 years later my husband to cancer. I could be defeated by that, or I could be creative by that and make some reasons to still have a lot of joy. I would always feel extremely grateful to the doctors that have made my life what it is today. No matter what it is that people pour their heart and time into, I especially appreciate it when it's something that benefits other people, gives joy to other people, or in the case of medical procedures, gives life itself.
Wow, Dr. Rizik.
Isn't that a great story?
Great story. Meeting those two was amazing too. And this is such an amazing, and we could say groundbreaking procedure.
Absolutely. You know, the highlight for me was meeting the pioneers, meeting some of these patients to relive their stories. But I also very much enjoyed the fact that leading up to this, you actually had the opportunity to perform a TAVR procedure on a simulator device that our friends from Medtronic brought in.
Yeah, and it was just so amazing to see what you guys are going to do here through this simulator. Take a look.
So, Brad, when Dr. Burke and I talk about doing these procedures, when we're first learning them, learning how to do these procedures, we say see one, do one, and then teach one. That's the cadence. Where you're going to get a chance to do one using this model. This is a model from Medtronic, and the device we're actually going to put in is this valve, okay? And this valve is going to go into, partially into the aorta, partially into the main pumping chamber of the heart, the left ventricle, and once it does, it'll open and close with each pumping motion or cardiac cycle.
Wow,
okay?
that is so amazing that this is going into someone. This size here.
That's right, but it is crimped. It is crimped on this catheter. So this is the delivery catheter, very similar to what you're seeing here. This is the delivery catheter, and what you'll do once we get the valve into place, we will turn this knob this way, and the valve will eventually open up into, in this model, the heart and the partially into the aorta. All the time that we're deploying this, Dr. Burke is giving us real-time feedback with cardiac ultrasound or echocardiography.
So, Dr. Burke, what's something that we should be looking at when we are watching this being put in?
So what you're going to see is that it's going to open up from the bottom to the top. Okay, so the bottom opens up and it flares. So what happens specifically is this will be closed. This will be all crimped down, and then it's going to come out and it's going to spring out in this direction as you guys open it up until eventually you decide to release. So this actually pushes against the native valve, the aortic valve that's been diseased, and secures it and allows it not to leak around the valve. So you go from a valve that opens up, you can't even see the opening, to something that's going to open up and you have that nice wide open view of the valve. And with every heartbeat, it opens and then it closes down again.
And that's what we're going to be doing. Wow, this is amazing. Okay, I know we can't do it alone. You also have someone standing next to you, who is here to help us, who's there in the operating room too with us, right?
We have Brenda Arnold. She's an expert from Medtronic, the company that makes this valve. She's our eyes and our ears in the cardiac catheterization laboratory when we're implanting these valves, and she's really an expert on how to prep this device and how to work this device.
Wow, okay, I know we have one set up already before we start, but here is one that isn't. This is what we are going to be using, right?
That's exactly right. And so as it's being advanced, this lever here or this knob here has the arrows, and it tells you which way to turn this. So as Dr. Burke said, it opens from a bottom to top configuration once it's in the old or diseased aortic valve.
All right, I'm ready now.
All right,
let's do this. All right, so what are we going to do?
All right, so what I'm going to do is I'm going to advance the valve. You can see the valve being advanced here, all right? And now it's coming over what we call the arch of the aorta. Brenda, will you give us a little wire tension on the back end?
Okay, so, that's what I'm supposed to be doing?
No, that's Brenda's job.
Okay.
This is being advanced around the aorta. Dr. Burke, would you show everyone where the aorta is?
So the aorta is going to be right down here. There's a black dot that you can see, and there are two tubes that are sticking out which represent the coronary arteries, which supply blood to the heart muscle itself.
So now the valve is coming down, and I think we're going to stop about right there. What do you think, Dr. Burke? Is that pretty good?
That's looking good. So we're looking at right at the annular level, and that's where this valve is going to secure itself to hold itself in place safely.
What do you think, Dr. Perry?
Dr. Burke, it looks okay?
You look great.
That's what I do right there. Okay.
He concurs.
I concur. So I do have a question for you, because right now we're here in a simulator looking down at this, but
Right.
you guys are actually having to look on a monitor doing this, right?
Dr. Burke?
Yes, so exactly what we do is that we'll use echocardiography, ultrasound, and also X-ray fluoroscopy to look at this in real time while the heart is still beating, and be able to see where the valve is, how deep it is, and determine whether or not we're in the right place to allow that valve to open up and then to be released.
We call this multimodality imaging. We have right in front of us several TV screens. One is an X-ray machine. One is the images that Dr. Burke is giving us from ultrasound. And so using multiple imaging techniques, we can perfect the implant. And having those multiple imaging techniques makes it really fast and slick.
Wow, okay. Where are we at now? I'm going to let go of that?
No, you hold on to this. What I want you to do is hold right here with your left hand, and with your right hand, the arrow's telling you which way to start spinning it. So start spinning it, and you'll see the valve is going to start to deploy. Start spinning it.
More? Faster?
No, just at that pace.
Nice and smooth.
Okay, keep coming. Keep coming. That's great. Keep coming. You'll see it start to open.
Dr. Burke, how's it looking?
We look fine. You still got a ways to go.
Okay.
Okay.
See how I learned that, Dr. Rizik, to ask?
A little bit deep.
So now Dr. Burke is telling me we're a little bit deep, and he'd be telling me that on ultrasound if this were a real case. Keep going.
Oh, keep going?
Yep.
Okay.
Look at that. Starting to flower. And as Dr. Burke said, from the bottom up. Dr. Burke, do you like my position there?
Might be, that looks pretty good. Maybe a little bit deep, but we're looking good.
Okay, I'm stopping somewhere.
Okay, now you'll get those rumble bands. You'll hear that. Now we're going to just keep opening through that. Keep going, keep opening through that. Keep going,
Okay.
You're great.
Okay.
Now look at it starting to open up completely, and then, did you see that little pop?
Yeah.
You have just done what I would consider to be a near perfect deployment of that valve. So the valve opened, as Dr. Burke showed us, from the bottom up, and then there was a little, because this is a very springy material, it's nitinol, it pops open at the very end.
Wow.
And now come and look at, but Dr. Burke, you want to describe so Brad can see what he's actually done there?
So what you've done here is that you can see the very bottom of the valve, and there's a little wrap around this with pericardium to prevent any leak. You can see where that black dot is. That's the annulus, and that's where it's going to be anchored fully. You can see that you're perfectly there. You're holding this on as well as you could possibly hope to. You've got the coronary arteries, those two little tubes, that are well above the level of the valve. So this is perfect. So you can still get at those if you need to do intervention like Dr. Rizik does, if somebody's having a heart attack or otherwise needs a stent or something else done. So this was perfectly placed.
You know, there's a story that you and I talked about, our friend Glenn. He was actually a patient of Dr. Burke's. And this is a gentleman who we first learned that he had valvular heart disease several years ago. And he was in his 90s. I mean, this gentleman was really quite up there in the years. But because of this technology, he lived another 7 or 8 years and did beautifully over those 7 or 8 years. And there's a great story that I think we want to share with our audience.
Let's take a look.
I'm Glenn. I'm 97. I wake up in the morning with nothing to do. That night, only half of it's done. That's how busy I've been. Spent 3 years in the Marine Corps. I worked at Caterpillar Tractor Company. Spent time in Brazil. Fished and hunted and played golf, played cards. Had a great life.
Well, we've been married 73 1/2 years, but who's counting? His health was excellent up until gallbladder surgery, and that led to Dr. Burke discovering that he had a heart valve problem. We did not know that.
I passed out a few times, and they decided that I needed a new heart valve. And I was too old for open heart surgery, so they went up to the groin, and it lasted over 6 years.
Well, I've known Glenn now for the better part of 10 years and have been taking care of him. He was one of our first patients to ever have a TAVR placed going back roughly 7 years ago. So TAVR, or transcatheter aortic valve replacement, is where we put in a brand new aortic valve without doing open heart surgery. by using a catheter to put a new valve inside there and push the old valve out of the way.
In most of the cases, TAVR implants are extremely successful. And initially in Glenn, he was symptomatically very much improved, and we were very happy with our initial results. But over time, the valve began to degenerate or change, and then he became somewhat symptomatic.
I went 6 years and I played golf and I fished and I traveled and I did everything.
And then the second one, that was very obvious because it just kind of happened overnight.
Life was not enjoyable. I just began to feel, I might say awful, but no appetite and no energy. I stopped walking 1.5 miles. It was just not a good life.
So when you're evaluating a 97-year-old person, there's always a question of what is the appropriate thing to do. Is it safe to do any procedures? Is there going to be any benefit to the procedure? And in this case, we thought there was a benefit to prolonging his life and improving his quality of life.
I mean, he's 97 years old, but he's 97 going on 60. He's got a lot of energy, and he wanted to get better.
The best option for him at 97 years old was to place a new valve inside that space.
We decided to use the new Boston Scientific Lotus Edge TAVR device because some of the attributes of that might be able to seal the leak he had in his old valve. When we implanted the Lotus, initially we were very pleased. Much of the leak that he had surrounding the old valve had gone away, but we still had a little bit of leak left. So we decided to put a vascular plug in alongside the Lotus valve, and that worked beautifully.
The results, I think, are even better than they were 6, 7 years ago. They released me on Sunday, the 16th, and I walked that Sunday, and I walked the Saturday, and I came home, and on Monday I was able to walk 1/2 mile. And within 2 or 3 days, I was up to 1 mile, and I'm over 1 mile most every day.
We saw him back in the office last week, and in his own words, we gave him his life back. So he's back to doing his walks, feels significantly better, and our hope is that we're going to keep him around for another 7 years or so, just like we did the last time.
We think we have a very good life. We don't know how much longer that will be, but we're hoping for a few more good years.
Keep active. You got to keep going and moving and do things. Live every day and be active, and I just can't tell you what a fine group of doctors and nurses that I had 2 days in the hospital. I enjoyed it. I had the right team of doctors, and can't give them enough credit.
Wow, that is the type of excitement we like to see after one of these surgeries with Dr. Rizik.
No question.
I want to welcome you to the procedure. If you're just checking in with us, we are about to perform a live heart procedure, aortic replacement.
Aortic valve replacement.
Thank you very much, Doctor. I'm starting to get nervous because this is where we're actually going to be doing it live on the air. And again, Dr. Rizik, a great team you have here, so let's introduce the room.
Okay, so first of all, we introduce Dr. Robert Riley, my colleague and extraordinary cardiothoracic surgeon. We're going to partner on this. Our anesthesiologist is Dr. Harrison. Dr. Robert Burke, our extraordinary echocardiographer for many years. You've seen him in these procedures previously. We have a collection of nurses. We have Melissa, we have Sevda, Jamaica, Sophia, Aaron, and John. A great group of nurses and patient care technicians that are going to all assist. Everybody has a very specific role. And then we're just absolutely delighted to have our clinical support team behind me from Medtronic. They help to prep the valve and do other clinical support things during the procedure. And none of this is ever possible without our friends from Siemens Health and Ears. They've been terrific, terrific partners throughout all of these procedures that we've done.
That's amazing. Okay, before we get started too, I want to remind people the way I'm standing right now is important because I'm not sitting here, I'm not bored. I know people say, you know, with people's arms, you look like you're bored, but this is where I'm supposed to keep my hands right in here because there's a lot going on in here and you want to really pay attention to what is happening here with this amazing surgery.
Dr. Riley, give us orientation of where we're at on the patient.
Okay, so to set up before we went live here, the patient is lying flat on his back on the table here. Head is up to my left, feet are right here. We are not going through the chest. We're doing this whole procedure through the groin, and we have a catheter in the groin already here for prep, and we have a catheter in the wrist over here. So between those two access points, we'll perform the valve implantation.
And so you can see a lot of imaging, Brad.
Yeah, so what are we looking at right now on these screens here?
On the screens to the left, we have X-ray, moving X-ray, which we call fluoroscopy. To the right, we have ultrasound or echocardiographic imaging, and no one better to explain what we're seeing on the echo images than Dr. Burke. And in fact, I think what you and I ought to do is start doing our procedure, getting our catheters in place. And Dr. Burke, could you explain the fluoro and the echo, please?
So fluoro, that's the X-ray imaging that we have, and so we can see straight through the body. In this case, you can see some wires there that are from the prior sternotomy. That's where he had his prior open heart surgery. And then we've got some wires and tubes inside there. Those are the catheters. And that allows us to see exactly where tissue is going to be. So unfortunately, the heart is invisible on X-ray. You see right through it. And that's why we have to use echocardiography. That's the ultrasound that I'm using right now to be able to look at the valve and see exactly where it is and also where these catheters are. So that's how we help to guide the procedure. And what we're looking at here on my screen is the aortic valve. On the left side, we're sort of looking down on the valve itself. And on the right side, we're cutting through it at a 90-degree angle.
What do you need?
Wow.
Balloon,
So we
please.
can also throw
Balloon.
color on here that shows blood flow. And in this case, you can see that there's blood flowing backward because we're actually splinting, we're keeping the valve open even when it would otherwise be closed. And that's because of the wires.
Dr. Burke, you've shown us all that calcium on the valve, and before Dr. Riley and I made the decision that before we just proceed with placing the valve, that what we should probably do is try and balloon this this catheter, or use a balloon catheter to dilate up the calcified stiff valve.
Absolutely. You can see
Balloon
calcium right
on
there and there
catheter.
and there.
So if you can show this balloon close up, we're going to move this balloon all the way up. Go ahead, Bob.
This is on the wire right now.
There, that's perfect.
And then we'll pass that through the catheter, the sheath that's already in place here.
Fluoro.
And then we'll look at the fluoroscopy machine ahead of us and pass it to our mark.
Wait 1 second. Now, Dr. Riley is in position 1. He and I alternate who's going to be in position 1 and who's going to be in position 2. Position 1 really positions the valve. Position 2 is the one that unrolls the valve into the valve complex, the old valve.
And here on the fluoroscopy, we have these two markers that show the beginning and end of the valve. And we'll just right now pass across where that little curlicue catheter is, the pigtail catheter. That's sitting where the native valve is. So we're halfway across it right now.
And you can actually see calcium where that, go on fluoro. You can actually see calcium on that. Go ahead and run that. Where that pigtail catheter, that curled up catheter is, you can actually see calcium. And we're going to try and crack that calcium with this balloon before we go in with the TAVR valve.
So while we're doing that, we'll ask the anesthesiologist to pace the heart at a fast heart rate so that the valve and balloon don't move, and then we'll inflate it with this syringe here that Dr. Rizik has. So Dr. Harrison, if you'll hold respirations and then turn the pacer on at 180. So we have good pacer capture, and now the balloon is going up. And
there, we cracked the valve pretty well. Now the balloon is coming down.
Pacer off.
Balloon is coming down.
And fluoro save that.
Doctors, why did you have to crack that calcium?
There's so much calcium on that if what we try and do is just use a valve to go in there, the valve might not sit right and it might not open up perfectly. Fluoro, please. The valve might not open up correctly because of that stiff calcium. So we're going to crack the valve first before we go in we're going to crack the God-given valve before we go in with the new TAVR valve. And you see that Bob and I are just kind of working at a regular pace, very smooth, sort of uneventful deployment so far.
So let me also explain to people there, why are you going through, well, you explain why you're going through the groin and not opening the chest like before.
When you go through the groin, there's no body cavity that's open. So the recovery is basically just a flesh wound. So that there's no prolonged need for pain medicine or avoidance of activity.
Yeah. And it's just amazing that from our groin can reach our hearts, and that's by following a vein. Is that right, what's happening?
The artery. So we go through the femoral artery, like you saw in the animation, and then pass the wires and catheters up the aorta, and then across the native aortic valve.
Wow.
Okay,
Amazing.
the next thing we're going to do now is place the valve in. This is the valve, just like that simulator that you used. So, Bob,
can I have a dry lap, please? So now we're going to take out the catheter that was our placeholder and put the valve in through that spot in the groin.
and you can see this is like a, what did they say, a four-handed piece of music. Dr. Riley and I are moving, all of our movements are together.
Okay, you want to back it out?
Yep. All right. Tell me what you think about my wire position. I think we're in good shape.
Okay, I have wire.
Okay. And Sophia, who's very experienced, is going to hand me my valve now. She's going to start it on the wire. All of these valves, like the previous devices that you've seen us use on the procedure, everything goes over a wire. So not unusual for these types of procedures. There's a wire all the way up to the heart, and this is going to similarly go over a wire up to the heart. Dr. Riley is going to do most of the positioning. He's going to decide where the optimal position is. Sophia, hold that wire. And then what I'm going to do is I'm going to unfurl the valve once we're adequately across. Wait 1 minute, Bob. Okay, go ahead. I'm ready for you. I'm going to unfurl it as we get into a proper position at the old diseased aortic valve. So you can see at the bottom of your fluoro screen the catheter coming up, the new valve coming up, okay? All right, wire, hang on, wire.
Wow, that is just amazing to see it
Okay,
in
go
person.
ahead, Bob. Got my wire position.
Yeah, we're going to move the pigtail a little bit, but
Okay, go ahead.
pull wire back a little bit.
Okay, wait, fluoro. Good, good, perfect, okay, good.
Implant angle, please.
So now you see that TAVR valve. Now let's do this. Give me a little toot. Give me some contrast. That worked perfectly.
Yeah,
All
we
right.
don't even have to move.
All right. So, Bob, I'm going to do this. You be the captain on this one.
Okay.
You make the call when you want pacing and everything. So we have one person communicating as we do this rather than multiple people.
So let's pull the wire a little
Okay.
central.
All right.
Dr. Harrison, will you turn the pacer on at 120?
You like that
That'll-
wire position, Bob?
Yes.
And Bob and I just alternate who's going to be in position 1 and who's going to be in position 2. That's the best way a heart team works. Everyone can do every job in the room.
So now you can see that there's less motion, so we can keep our marker right there at mid-pigtail, and then we're going to open up the valve. If you look at Dr. Rizik's hands, he's twisting this, and it's kind of pushing the valve, or unsheathing the valve, pulling the catheter off the top. So we're a little high. I'm going to come down to right about there.
Now, you notice what Dr. Riley just did. While I'm unfurling the valve or opening the valve,
Pull the wire in a little neutral.
you do the wire, okay, Sophia? So it's really becoming a six-handed procedure.
Let's
today.
hold here. Dr. Harrison, let's pace at 150. And this valve is repositionable, so if we don't like where we land, we can always recapture and put it in a different spot. Pull wire, Sophia.
Oops.
All right, now push it in a little bit, Sophia.
What do you think, Bob?
Yep.
Okay, I'm going to keep going. And this is just a nice casual pace that we're not a rushed procedure, just a casual pace. And you hear that rumbling sound. That means you're near the end of travel for this valve.
Pacer down to 100, centralize the wire.
Dr. Burke, would you mind stepping in and telling us what you think about the depth of this
Off
valve
on fluoro,
implant?
let's do a cine so you can see
So
it a
on
little
this
bit.
image right here, you can actually see the valve. We're sort of looking at it, cutting it right through the middle. You can see where the valve has landed here. It's just below the actual annulus, just a tiny bit. And that's really where we typically like to see it. Looks like that's opening up very well right now. Now, don't forget, this is a memory metal. It's nitinol. It's going to expand over time, and it continues to do that because it wants to get back to its original shape.
That's a very, very, very important point. When we put this in, nitinol or nickel titanium, is when it's cold, they prep it in cold water, it's very small. Dr. Riley, what happens when it comes in contact with the warmth of the blood, 98.6 degrees Fahrenheit?
So it will return to its natural state, so it'll expand.
Right. Okay.
Let's push wire a little bit, see where we come down to 80 on the pacemaker.
Dr. Burke, our depth, are you happy with that?
Looks like we might be a little bit deep there below the left.
So,
right
Dr.
now.
Riley, do you think it'll come up on release, or what would you like to do?
I think that let's do a different modality. Let's go ahead and inject contrast here and see our depth based upon the fluoroscopy as well.
You ready? Go ahead.
I think we're talking the difference of millimeters here. I think that
Pretty happy with the way this looks. What do you think? What would you do if, what do you think we should do? We have the option, I asked Dr. Riley that, we have the option of recapturing this or deploying it just like it is. So what should we do?
I think that we should pace and deploy it where it is.
Okay.
I think that the right side of the screen will rise up a little bit as we release it, and it will center itself.
And keep in mind, Brad, this entire time, this is a casual conversation between us with our anesthesiologist, with Dr. Burke, our echocardiographer. We're not rushing. We're moving at a methodical but progressive pace.
Yeah. And so for those at home, you said that you put a dye in there. What's the dye to do to see where actually things are pumping and going with it?
It shows, it helps to show the valve. It helps to show the depth of our implant. We don't want to be too deep. We don't want to be too high. We want to see the coronary arteries. You can see the coronary arteries filling. You can see the entire landscape where we're working when you put the contrast in, and when Dr. Burke advances his echo probe, you can see the echo probe just to the left of the valve on that screen. Dr. Riley, anything else?
Just still debating whether we should make it 2 or 3 millimeters higher.
Okay. Then I have to say we do it.
Okay. All right.
Okay. So I am going to recapture this valve.
Centralize the wire so it doesn't become aortic.
Okay.
Pace at 120, please.
So now you can see very easily I'm reversing directions with my dial, and we're recapturing the valve. And we can do this multiple times until we perfect the position of the valve. And Dr. Riley has probably the most important job right now. He's trying to make sure that valve stays centralized and doesn't dive into the pumping chamber or into the aorta.
And Dr. Rizik, that's why this surgery is so important, because before, if you had the chest open, you had to move very quickly and have to get things in place and not really knowing. Here you're able to make the move if you need to.
What do you think about that?
Right about there.
Okay.
Yes.
And what do you think about our wire there?
Let's
Dr.
check our
Riley?
pigtail catheter.
Okay, let's give a toot there. I think that may have, actually it's perfect. Oh, that looks perfect. Okay. Pace at about $150, please. And
So Sophia, we're going to pull the wire a little bit here. Stop.
I love your depth right now, Dr. Riley. I love the depth. So now I'm going to move a little bit faster in deploying this. Now, Dr. Burke, you're up again.
Pacer down to 90. So I think we moved the valve up of probably 3 or 4 millimeters.
It looks like a substantial movement.
So the impressive part is we moved about 3 millimeters and we're 180 centimeters away from it.
I mean, think about that. This is 180 centimeters, and we're talking about millimeter movements, but that's the difference between a good deployment and a less than perfect deployment. And what we shoot for, Dr. Burke, Dr. Riley, and I, we aim for technical perfection, because what we leave this patient with is going to make the difference between whether this patient has long-term durability of the valve, has symptoms after the procedure or not. It's extremely important to try and achieve technical perfection with every one of these valve implants. Dr. Burke?
80.
This is looking great. Might have a little trivial leak there, but
Centralized
that
wire.
will typically go away over time as the valve continues to expand.
Boy, I love this. I think this is a keeper. What do you think,
I think
Dr.
I'm going to
Riley?
lay over a little bit while you release it,
All right.
and we'll release it with pacing again. What do you
Okay.
think?
Why don't you make the call?
So let's pace at 180.
Are you on, Bob? Yeah.
Yep.
Yeah, Bob.
Centralize the wire a little bit, and we're going to release very slow, and you'll see at the top of the marker here, the valve will open up there.
Oh my goodness, look at that. Okay, I'm still on
And-
one. I think it just gave.
Still call it.
Okay. So do your thing, Dr. Riley. Go ahead and drop the pacer a little bit. There it is. Now we just released.
All right, centralize the wire.
Okay. Okay. Want to retrieve? And there it is. So now the valve is out. Okay, so Dr. Riley, would you do me a
Pacer
favor?
down, please.
Would you give me a new 035 wire, an 035J? You can pull the, let me capture this first. All right, fluoro, please. Live. Show that, please.
Come down.
Aaron, come down, please. Thank you. That's perfect. Perfect. Okay, may I have an 035J wire? You can take that. Dr. Burke, position.
This looks great.
Okay, could you, I'm going to fluoro now, could you go up to the new valve? Now you can see Dr. Burke's probe is there. Bob, come back just for a split second.
Let me have a J wire, please.
Okay, now I'm going to do a cine.
Let me have the short J.
Capture this, and there's the new valve.
Wow.
That's it.
That's right there. That's it.
Dr. Burke, on a scale of 1 to 10, what did we do?
This is great. This is a 10.
All right.
So, doctor, since you put in the new one, where does the old valve go?
Great question. I was always told when the host of the show asks a question, never say that was a great question, because that's his job, but that was a great question. We just sort of, Flora, please. We just sort of wallpaper over the old valve. And that's the best way to think of it, is wallpapering. We push the old valve aside. Now, different from surgery. When we perform surgery, Dr. Riley cuts out the old valve, correct, and sews in a new valve.
Correct, as opposed to wallpapering over it.
We just push the old valve aside, put a new valve in over it, and that's it.
Well, how long will this one last?
You know, that's a great question. Bob, you've been doing surgical valves for decades. We know the durability of surgical valves very well, don't we?
Yes. This valve is built off of the same platform, so we're optimistic that it will last as long as a surgery valve, but there may be some things that happen when you crimp it and make it small before, so you could pass it in through the leg. But we have very good durability for the 10 years that we've been using the valve.
And I think that's the great point. We've been doing surgical valves for 50 years. This is 10 years old, this technology. And so we're still trying to learn and understand how long these valves are going to last. So we're still sort of in the infancy stage compared to surgical valves, but the technology has moved so rapidly that we have great optimism about this.
So, all right, if someone's wondering now, going, okay, so maybe I need to get a new valve, something like this, do you go back in and take the old one out, or do you replace it, like you said, to expand in that area?
Well, there are several choices. One, we could talk to Dr. Riley about going in and surgically removing this valve, or we can do what's called a valve-in-valve. We can go inside this valve with a new valve and make open it up all over again if this valve should degenerate. We do that with surgical valves that degenerate, and we do that with catheter-based or TAVR valves that degenerate. You always get another chance if the valve should fail or degenerate over time.
Okay, so this, I mean, this went pretty quick for people who are watching at home going, wow, this is very fast. But what about recovery time for the patient?
Dr. Burke, you want to talk about recovery?
So recovery time, as Dr. Riley alluded to earlier, really is much, much faster because really it's just dealing with the access site in the groin where we access the artery. So people are often home within the next 24 hours.
Wow. So amazing as you're going through this, and the teams of compressed.
So the next step in all of this now is we're going to close the hole, the very small hole in the groin.
So let's just load the manta up then.
You want to just load the manta? Okay. The next thing we're going to do is close the hole in the groin so that in a couple hours we can sit the patient up. We have several different devices, some suture-mediated devices, some collagen plugs to close the hole, but in either event, we are going to do that right now. I'm going to tell you
Protamine, please.
And some of the blood thinners that we've given, now we're giving medications to reverse those. You want to do this, and I'll step over?
Absolutely.
Could you help Dr. Riley do this, please? And then Brad and I will step over here.
And out of the way here. So as we've seen this happen, people are probably wondering, okay, you said that he had open heart surgery. So you can actually do this surgery even with someone who's had open heart surgery.
You know, when Dr. Riley and I talk about this procedure, he reminds me that we came up with this procedure as a profession, especially for those who have already had open heart surgery, so that they don't have to have a second open heart surgery. Remember something, open heart surgery is done all the time. It's a great technology. But if the first valve done surgically fails, so that we don't have to open the chest again, we can put one of these transcatheter non-surgical valves inside the old surgical valve, so that we don't have to cut the chest open again.
If someone's sitting at home right now watching this and maybe not feeling well, and maybe you think it's their heart, what are some of the things they need to look for when they do want to call their physician?
Yeah, you know, the symptoms that we talked about, we talk about shortness of breath and fatigue, probably far and away the most common symptoms. So if you are feeling shortness of breath and fatigue, especially if you're over 70 years of age, because most of the patients that we do are over 70. But if you're starting to lose some of your exercise tolerance, and you're starting to get short of breath, some of the stamina is not there, then I think you should get to your doctor and get evaluated, get seen. If your doctor hears a heart murmur or has some clue, if the antennas go up to suggest that there is a valve problem, then that primary care physician, internist, family practice doctor should get you to a cardiologist for a cardiovascular evaluation and someone like Dr. Burke to do an echocardiogram. Yep, Bob.
So as he steps over that way, you can see that they are working here. And if you're just tuning in, this is a live heart procedure that we just did here at Honor Health Shea with Dr. Rizik and his team, which is amazing. It was a aortic valve replacement. And we'll have more of it on aztv.com/procedure. But as they're going through things, they're checking things out. And again, successful with this team here, which is so amazing. So we do want to ask you, Doctor, again, when will this patient be able to go home?
Well, Dr. Burke did much of the workup of this patient. Dr. Burke, in your experience, how soon will these patients go home after this procedure?
So on average, our experience here is that they go home within the next 24 to 36 hours. So starting early in the morning, typically we'd expect to take another look at them in the morning, following, recheck an ultrasound, make sure that the heart looks good, and then hopefully around lunchtime, be on their way out the door.
I do want to draw your attention to one thing, and this is really a great procedure in that Dr. Riley has the opening in the groin closed already. That's it.
Wow, amazing. And that is
20 minutes, skin to skin.
And that's our live heart procedure. Dr. Rizik, again, I appreciate you inviting me along with our AZTV, of course, viewers into the operating room to do this, and it's amazing. We do want you to see more by going to aztv.com/procedure.